It's now my pleasure to introduce our second speaker, Dr. SAAD OMER. Dr. OMER is a professor of medicine and epidemiology at Yale University, where he is the inaugural director of Yale's Institute for Global Health. He has over 300 peer-reviewed publications to his credit, including many studies of interventions intended to increase immunization coverage and acceptance. Dr. OMER will be speaking today about the global state of vaccine confidence and how do we enhance the uptake of vaccines. So welcome, Saad.
It's my pleasure. Could you just confirm that everyone can see my slides?
We can see you and hear you.
All right, that's great. So it's my pleasure to speak at this forum, and I'll be talking about the big picture, but also how do we enhance the uptake of vaccines, and just just whetting everyone's appetite and in terms of the various interventions that our group and some others have been exploring. This is not an exhaustive list of the evidence base, which has increased substantially, fortunately, over the last few years. So regarding COVID-19, this was late January, and I had an op-ed that came out in the New York Times on January 23rd. And as I recall, there was just one confirmed case of COVID-19, and the virus wasn't, the syndrome wasn't called COVID-19 at that time. The virus hadn't been named properly. But some of us saw really concerning signs. And so this op-ed asked the question, is America ready for another outbreak? The question could have been asked about many other countries, but in the context of the US, the response was no. And it wasn't a sort of a glib thought process. I went through what we were gearing up to do and what was out there, what was the state of preparedness. Obviously, a lot of us couldn't have predicted that the high number of cases and mortality specifically, but we were concerned about where things were going. And at that time, I had three warnings. The first one was let the scientists lead. And it's not just I was sort of looking out for my brothers and sisters in science. The reason was that communications research and research on pandemics and our experience on pandemics suggests that, first of all, messaging coming from an authoritative scientific perspective carries more trust with it. But also at that time, we knew and that the pandemics are a very dynamic situation where the information evolves. Even the hardcore, setting aside misinformation, the hardcore evidence-based information also evolves. So the idea was to make sure that the ability to synthesize that new emerging evidence and assimilate that is closely coupled with the ability to take actions. And to ability to communicate that evidence more clearly, and including the uncertainty about the evidence. The other thing I warned against, again based on evidence from previous public health emergencies, including large outbreaks, is that there is a reasonably or an understandable instinct that leaders have, public health authorities, political leaders, and so on and so forth, to provide assurances. And in the short run, it does calm down the public. But in the long run, you lose that cachet and the ability to then communicate difficult mass recommendations if you reassure without the evidence of such reassurance. And the last thing was that it was emerging, even on, this is January 23rd, the byline is, the date is January 23rd, that there will be misinformation around it. But also that misinformation will come from some unprecedented, at least at that time, sources where, because I could see the explosion in preprint servers and the propensity to share one's output earlier on. And there was, a reasonable case for that. And I have shared it in preprints as well. But the fact that it doesn't go through, a lot of the information doesn't go through peer review, and that critique and that quality control means that it exacerbates the issue of half-baked stuff coming out prematurely and then muddling the picture. Unfortunately, these three warnings that has implications on communications broadly around around the epidemic, around the pandemic, but also specifically around vaccines, turned out to be a little prescient. So this is the big picture. This is a fairly useful map that was created by the Vaccine Confidence Project based on 2013 data, and that looked at vaccine hesitancy using a measure that was administered. And briefly, what it illustrated to me was that vaccine hesitancy, and different names to the phenomenon, and so soft demand, hesitancy, etc. But vaccine hesitancy is a global phenomenon, it's widespread, but it is heterogeneous. And that's the take home that I had from this kind of work. There's more recent data that Dr. Larson was nice enough to share that is coming out from the Vaccine Confidence Project. And I'll present this snapshot from 2019, which asked a simple question. I think whether you agree with the statement that I think vaccines are safe. Similarly, even more recently, there is heterogeneity, and there are hotspots in Japan, South Korea, France, Eastern Europe, and so on and so forth. And so we need to be mindful of certain attitudes. Not all of these attitudes lead to actual refusal, but it is important to monitor these attitudes, especially at a global level and on an ongoing basis. So how do we do? Our initial instinct is to correct misinformation. And there is some evidence around the utility of correcting misinformation, but it is nuanced. So it's not one-dimensional. So I'll just present one study, but just keep in mind it's just one study, and I'll add some context to it, that was conducted by Brendan Nyhan and his group and his colleagues that looked at facts-based messaging and that divided parents coming to doctors' offices for pediatric vaccinations into three groups based on their starting attitudes, baseline attitudes. Those who were most favorable towards vaccine, somewhat, or least favorable. That's the leftmost panel. And there were different interventions there, ranging from images, narratives, risks, correction, and then control group. And it turns out in that study, those with least favorable vaccines had actually a lower, so there was what was described at that time a so-called backfire effect of correcting misinformation. They had a lower propensity towards vaccination and after the intervention. And I would say that the data are more nuanced. Not all myth correction has panned out as having a backfire effect, but it does give us pause in terms of in terms of our go-to source for myth correction as a primary intervention strategy. And so what are the other options? So one thing that we have been studying in our group is underlying values. Turns out a lot of us have, or actually all of us have underlying values, and they somehow work like taste buds. So there are, 5 primary tastes: bitter, salty, sweet, umami, which is a savory taste that is more prominent in dishes from Southeast Asia specifically, and sour. And the way we taste a flavor of a food is based on both, what is the permutation of taste buds that food evokes, but also our underlying propensity to certain flavors. And so taking that analogy, Jonathan Haidt, Jesse Graham, and others sort of postulated this theory called the moral foundations theory that says that we all have 6 moral taste buds. So these taste buds are more or less common. They're emphasized differentially in different populations, and stimuli are different in evoking different combinations of these values. So what it does is that this way of looking at values makes them measurable, it makes them specific, and you can sort of develop interventions to that. And so the first value is the most hardwired value, which is the care harm. This is the reason why we want to protect life. This is the reason why we find sort of cute animals cuddly. Then the next one is fairness cheating. So most ethics systems have the golden rule in common. And so we inherently get this reaction to unfair situations. So the next one is loyalty betrayal. For some reason, we cheer for our sports teams, we cheer for our countries, etc. And there are other ways of manifesting loyalty, and then the opposite of it is betrayal. And then authority subversion. And so the idea is to say that we have some people are more submissive to authority than others. Purity degradation. So that can be a religious valence based concept. For example, we have people, some religions emphasize evolutions, but it can be very secular, and it can be a situation where you have a situation where people don't want to put toxins in their body, and so that's one manifestation of purity degradation. The last one is liberty oppression, and that's also a common value. So what we wanted to see was whether vaccines decisions were value-based decisions, and we did this study in the US, and we found that those who were inclined to accept vaccines, so below 1 is acceptance, above 1 is hesitancy to vaccines. Those who wanted to accept the vaccine, or more likely to be accepting of vaccines, emphasize the authority foundation more. So that could mean that they deferred to their physicians, for example, etc. We measured that core value. We didn't measure specific attitudes, but that's all the more important that these underlying values were associated with how much they favored vaccines. Similarly, those who were more hesitant emphasized purity as well as liberty. So that study was the first time we showed that vaccines decisions can be values-based decisions. And so how do we sort of operationalize it, and how do we speak to people's values? So it's not our place to change people's values. So the idea is not to change people's values, but to speak to them. And so this is a new study that we did with colleagues, Aaron James and Avnika Amin, and my 2 postdocs, and a colleague and a former mentee at Emory, Bob Bernarczyk, and others, and Jesse Graham, who came up with the moral foundations theory. And we looked at purity and disgust to increase HPV vaccination. So the dogma, and so the main approach to increasing acceptance of HPV vaccines is through emphasizing the impact on cancer, which is entirely appropriate. But there are certain age groups where, in many countries, people teens miss these initial doses, and then they get to college where there is a substantial increase in sexual activity, and they're still not vaccinated. And turns out that there are serious limitations to cancer-based messages or severity-based messages for HPV in that age group. So what we did was we emphasized genital warts, and with images and narrative that emphasized the values of violation of purity values by the disease, we found pretty substantial impact in this randomized controlled trial that showed with this a priori primary outcome a substantial impact of approximately 20 percentage points in terms of the likelihood of getting HPV vaccine in the next 6 months. The other thing we need to keep in mind that we are excellent linguists but poor statisticians. A 4-year-old child or a 6-year-old child certainly can tell you the difference between boredom and sadness. But even if you ask, people like me, I look at among other things, safety of vaccines. If you ask me, what is the difference between the safe, what is the difference between a risk of 10 million and a risk of 1 in 10 million and a risk of 1 in 100 million? I wouldn't be able to tell you the difference, at least viscerally. And so we are, as humans, pure good linguists, but pure statisticians. And one way of thinking about it is focusing on the so-called availability heuristics that Amos Tversky and Daniel Kahneman came up with a while ago. And it says that people judge the probability of events by the ease in which instances could be brought to mind. So rather than to the actual frequency of it, for example, one example is that people are more afraid of flying than afraid of driving. And God knows we could use a few more drivers who were afraid of driving. But the reason why that is the case is probably because plane crashes are covered with more vividness and more sort of proactively compared to car crashes which are treated as a norm, unless it's a huge violation of the usual pattern. So keeping that in mind, I'm going to set this some context to this experiment that was done with different permutations that said that if you vaccinate your child and they pose different conditions, and one of them that chance of having a vaccine-associated side effect is 20 in 100,000, and the other one was, if you don't vaccinate your child, the chance of having the disease is 20,000 in 100,000, so 1,000-fold difference. And they said by manipulating these conditions, they wanted to see if that has an impact on vaccine acceptance. It didn't work. What worked then is the perceived severity of disease or adverse event. That mattered more. And when things were made equal, then if parents tended to focus on the regret from a decision not to vaccinate, than to vaccinate, because they thought that it's an active act of vaccination versus non-vaccination. And so that's called omission bias by some. And so the idea is to then frame vaccines as a routine act and non-vaccination as an active decisions rather than the other way around. Obviously, there are limitations to this. And as I said, the other way to address the shortcomings of this kind of an approach is to focus on values, perhaps. And so the bottom line is narratives of disease severity resonate more than statistical probabilities. So the other thing that we have been working on is the vaccine acceptance of COVID-19 in the US population. We found that approximately 70% of the high 60s to 70% of people were outright accepting or more accepting of vaccine. The others were not necessarily rejecting the vaccines right away against COVID-19, but they have concerns at this point that would say that they wouldn't necessarily accept it. And then we found the heterogeneity in the US population by region in this, and we developed and evaluated a predictive model based on commonly available demographic data to say, can we target our interventions more directly to these subpopulation group? And so this came out in, this was published a few days ago, and this work was led by one of my postdocs, Amin Malik. So what do we do when you cannot get out of correcting a myth? This is an approach. I'm told it is being updated, and I'm eagerly awaiting an updated version of it. This was developed by Cook and Lewandowski from Climate Change Communications. The idea is to think of a myth, do not emphasize the myth, focus on the correction or the assertion that it is a myth. So don't have a headline that says, does MMR cause vaccines? Are COVID-19 vaccines unsafe? That's unhealthy and inappropriate. Label, if you want to cover this, and if you want to present the information, say that the myth of MMR and being associated with autism refuses to go away, and so on and so forth. Clearly state that assertion is a myth, state why it's not true, and then replace the myth with the best alternative explanation. So it's like an empty real estate where you dislodge something and the the new information comes back unless you provide an alternative explanation. So focusing on that is helpful. This is a brief summary of current evidence. Don't affirm a misperception. Avoid lingering on a myth. Connect to people's values. And account for anticipatory behavior. Focus on narratives and no false assurances. So I'll pause here. And this is obviously a glimpse of the evidence that is coming out. I'd be happy to take questions when it's time.